Welcome back, clinical problem solvers. I thought everyone was already in, but I guess that was the wait list. Welcome to another RLR edition. We're very excited. Robbie has a boo-boo, but he's gonna get an x-ray and hopefully there's no fracture of that arm. Robbie, you look like Benzema right now.
Oh, sorry, Professor. I'm gonna figure out my camera situation in a second. But
Yeah.
yeah, it's amazing how many it's amazing how kind of like cool and sporty you feel with a boo-boo. You like
Yeah.
yeah,
Because you know Benzema kept rapping it regardless, like even after his injury had passed.
really.
Yeah, because it was just like part of
Yeah,
his routine. And you know how athletes are, like
that's
everything
true.
has to be in place.
What do you think? You think this is a permanent routine for you?
Robbie's gonna come to every unknown with that going
Was
forward.
that we'll see if we do well today, Gordon, then it'll stick. If not, I'll probably shed this.
Gordon, why don't you unmute yourself? Tell us a little bit about yourself.
Sure. Hi. Thanks so much for having me, guys. I'm an internal medicine intern at Penn in Philadelphia, and Mark, who's one of the Academy members on the call, was my senior resident when we saw this case last month on our general internal medicine service.
What was the diagnosis?
You'll find out
I'm
very
joking,
soon.
like I'm testing your wig, just joking. And we're very excited to get this case going. Robbie, you want to tackle the first aliquot?
You got it. Oh, look, I fixed my camera just in time. Yes, you got it, Prof. Rez.
You fixed it? Let's see that beautiful face.
Well, unfortunately, the camera's not that good, Prof. Rez. All right, Gordon, we're ready whenever you are, my friend.
Sure. So for the first aliquot, we'll start with our just chief concern. So we have an 87-year-old male who presents with bilateral lower extremity rash for the past 1 week.
Interesting. I think that we had bilateral lower extremity edema yesterday, and I think the question is a conversation about a similar location but a different presentation, which is the presence of a rash. And I think that what we articulated yesterday was the notion of local versus systemic diseases in the context of unilateral versus bilateral edema. And it's actually really telling that this is the same conversation we'll have about a rash. What we're going to try to do for the rest of the conversation around the rash is to really make the fundamental distinction. Is this a skin problem restricted to the skin, or is this a systemic disease that is surfacing on the skin? And I think that's the kind of big picture conversation we're going to have to use to try to make progress. So how do we go about doing that? I think we study two separate concepts, though they often get interwoven. But if you're thinking about this from a conceptual model, you're going to look for and study the rash itself and help you figure it out. Is it systemic or skin? And then you're going to look for systemic features independent of the rash. So since all we have is the rash now, let's just focus on that one arm, and then maybe we'll get more in the HPI about the absence or presence of the other. So what about the rash? Good thing, the simplistic thing is actually all you really need to know is how wide is the rash across the body? How deep is the rash in penetrating into the skin? And then the third dimension, which is what's happening as this rash tumbles over time. So we have two dimensions and we're missing the third. We know so far that the patient has a rash on both legs. What we don't know yet is how far across the extremities and how many places the rash is present that the patient may not appreciate. We don't know the depth because the depth is inferred by symptoms such as pain or observations such as ulcerations. And we do know the time course of 1 week, though we might look at the rash and make the inference that the rash has been present longer than the patient appreciates it. So as we listen to the rest of this conversation, we have one bucket completely empty, which is, are there any systemic features? And one bucket which has three subcategories, all partially filled. How wide is it? Well, we'll see how extensive it is across the skin. We know a little bit that it's in the legs. How deep is it? No idea yet. And how much is it evolving over time? According to the patient, 1 week, but the patient's eyes don't see the rash perfectly. So those are the categories that we're going to fill out. And I'll pass the mic to you, Gordon, to give us more information so Prof. Rez can either completely take this approach and
I'm
throw it
glad
in
you
the
didn't
trash.
pass the mic to me. I was like, what else am I gonna add?
No, Prof. Rez, feel free to pontificate whatever way you like with the more information that Gordon has for you. All right, Gordon, mic to you, my friend.
Sure. So 7 days prior to him coming in, he developed this painless bilateral lower extremity rash below the knees, and it came on rather suddenly. For the last month or so, he's had this lower extremity edema in his ankles. He started wearing compression socks to help with that. And about a week ago, he took off the compression socks and noticed the rash. Also, 3 days before he came in, he fell while trying to catch his wife who was falling. And he struck his chest, and since the fall, he's had like this chest pain and dyspnea. And so he went to a PCP appointment that morning prior to him coming in. And since the rash had progressed and the chest pain was getting worse, he was sent in from the PCP's office to the ED. But otherwise, he was asymptomatic.
By the way, Gordon, are you stopping here or you have more
I can
info?
go through his background information as well here.
Please.
So in terms of his background, he has a history of AFib, hypertension, and melanoma. For surgical history, he had a mitral valve repair about 30 years ago. He's also had Mohs surgery for the melanoma. In terms of medications, he's on amlodipine, hydrochlorothiazide, rosuvastatin, and rivaroxaban. No allergies and no contributory family history. In terms of social history, he lives with his wife in an assisted living facility. He's a retired Army veteran. He has no toxic habits, no smoking, drinking, or illicit drug use. And he denies any recent travel or sick contacts. He's mostly just been staying in the assisted living facility. I could stop there and then go on to exam next.
By the way, Gordon, have we met before? Have you been on VMR before? You just look very familiar.
A few times in the last month, I just kind of started.
Awesome.
Yeah.
Very cool. This is quite intriguing. Just one clarification question. Does he have a mechanical mitral valve?
He does not.
He does not. Okay, perfect. This is quite intriguing. And I say it's quite intriguing because we really have to map out the patient's symptoms and the sequence that those symptoms have occurred. If we look at the bilateral lower extremity edema, that preceded the rash. So when a patient has bilateral lower extremity edema, before you think about the three organs, know that the most common cause in elderly is venous stasis. In fact, half the population will have venous stasis by the age of 50, though in the majority, it's not that noticeable. But if you did Doppler with venous study, you will see valvular insufficiency. But you have to then consider the three organs of the heart, the kidneys, and the liver. And here we already, if we look at his background data, he has had cardiac issues. So this would just prompt me to take a review of systems for heart failure, including orthopnea, PND, and then track his weight to see if there's been any weight gain. It is true that he's not coming in with shortness of breath, but you have to be cautious because we don't know how active he is. And if he's just sedentary, he might not actually experience shortness of breath. The other thing that's interesting is that it seems the rash came after the application of compression stockings. So we're just mapping out the sequence of events. To tell you a funny story, I was attending in Baltimore at Hopkins, and we had a patient with a petechial rash. And I was quite certain that we were going to diagnose a small vessel vasculitis. I shared my framework of ANCA versus non-ANCA, and dermatology came by and they're like, what are you doing, man? This is just the compression stockings because the patient had thrombocytopenia related to DIC from infection, and so he was vulnerable to bleeding. So right away, I would want to know what his platelet counts are. And quite frankly, in real life, none of us would be doing the exercise we're doing right now, meaning we would just look at the rash. Because if it's a petechial rash, it will have a completely different differential diagnosis than if it is a confluent erythematous rash. But just the compression stockings being applied and then the rash developing makes me think, are you dealing with like some kind of irritant dermatitis that might be at play? Or are you dealing with some kind of trauma-induced vessel injury because the patient is vulnerable to bleeding? I'm not going to pontificate that much because, again, we just have to look at this patient's rash. But interestingly, he seems to have chest pain after having trauma to the chest. Now, that can be something that is as simple as musculoskeletal. If the trauma is severe enough, then you can get deeper pathology. Both you can get pulmonary contusion and even cardiac contusion, but that would surprise me. We have to understand that this guy is 87, so I bet you he has osteoporosis and his bones are fragile. So he's at very high risk for fracture. So I would have such a low threshold to do imaging. His background data, what that adds to it is that he's on a blood thinner, so he's more vulnerable to bleeding. And this might go back with our hypothesis of the compression stockings, but we still haven't answered the question, why lower extremity edema? So I'll be honest with you, at this point, I'm not really sure what's the problem that we're solving beyond lingering chest pain post-trauma in someone who's on anticoagulant. And what his complaint is this lower extremity rash. So the next steps is to really look at the lower extremities, do a good physical exam, looking at the JPP, looking for any signs of volume overload. And then once we have the physical exam, I think we can better characterize the problem that we're dealing with. Another problem might be, why did he fall? Was it mechanical? Is he having balance issue? Is there a neurologic issue? Is he weak? So you see, it's quite difficult to make more progress, I think, than that until we get more data. But let me pause and pass the mic to Robbie to see if there's anything he wants to add or just summarize where we are.
Rafraz, I have nothing to add. And as you were talking, I was just so struck by your reflecting on such a powerful clinical reasoning fact, which is that new events like compression stockings and trauma may be causal of the current clinical syndrome. They may directly cause it, or they may bring out a previously subclinical process in a much earlier fashion. So if your hypothesis of thrombocytopenia bears fruit, all that just happened was that the compression stockings and the trauma made it manifest sooner than it probably would have otherwise. So I think when you're trying to attribute consequences to certain events, you're open to one of three possibilities. Either the consequences are directly causal to the event, or they bring out a previously subclinical vulnerability, or they're true, and unrelated. And I think you can hear that in Prof. Rez's thinking. He's very open to it being a distractor, open to it being directly causal. But I think the most astute observation is he's open to it showcasing something else that would have not been otherwise detected. And I just, it was really cool to hear you touch on those three categories. And I don't know, I think in large part, we don't know what problem we're solving because we don't know which of those three things is the truth here. Is it completely unrelated? Is it causal or is it contributory? And I think that'll be, you need much more data to figure that out. All right, Gordon, please tell us more. We're very intrigued.
Sure. So I can go through kind of his exam and initial workup. So on exam, vitals wise, he's hypertensive to 165 over 101, tachycardic to 106, afebrile. His respiratory rate is 20, and he's setting well on 2 liters from a baseline of room air at home. In general, he's well appearing, no acute distress, and he's on those 2 liters. His neuro exam is completely benign. He's ANO ×3 with good strength and sensation, no focal deficits. In terms of his cardiopulmonary exam, he definitely had decreased breath sounds in the right lung base in the ED. It was pretty noisy in there, but definitely could appreciate decreased breath sounds. Cardiovascularly, he's mildly volume up. He has positive JVD and also has the 1+ pitting edema bilaterally to his ankles. Abdomen is benign. In terms of his extremities, he's warm and well perfused. He has that edema to his ankles that I mentioned. He also has in his hands a mild joint deformity at his MCPs and PIPs bilaterally, and some ulnar deviation of his hands. In terms of his skin exam, he has multiple 1 to 2 centimeter raised palpable diffuse petechiae that were coalescing on his bilateral lower extremities all the way up to his knees. No tenderness to palpation, no warmth or erythema. And then he had these diffuse hyperkeratotic lesions on his scalp, but no evidence of rash anywhere other than the lower extremities. In terms of his initial workup, he had a white count to 11 with neutrophilia, monocytosis, and lymphopenia. His hemoglobin was 8.6 and his platelets were 306. His sodium was 134, K was 4.3. His bicarb was 32, BUN was 32, and his creatinine was elevated to 1.23 from a baseline of around 0.9. His liver chemistries, AST was 26, ALT was 22, T-Billy 1.3, total protein was 7, and his alk-phos was 87. His INR was 3, PT 33, PTT 40. His NT-proBNP was elevated to 3,000. We also got just initial workup of a UA, which had 10 to 20 WBCs, 20 to 50 RBCs, and significant proteinuria. Initial imaging was a chest X-ray that showed a pleural effusion at the right lung base, and a CTPE was done, which was negative for clot, but showed the same small pleural effusion and no consolidated process. It also showed global cardiomegaly and a severely dilated pulmonary artery. And I'll stop there because that's a lot of information.
Oh my gosh. I just got to say, Gordon, I know you're a little bit over halfway your intern year, but your ability to capture this information and relay it so efficiently and effectively means that you have to understand it deeply. And to understand a case like this deeply is very, very impressive at your stage, and quite frankly, at any stage, honestly. So thank you for putting that on display for us to see. I'll just split this, Prof. Rez, and just take the real-time analysis of the exam and then have you layer on the labs. And I think at this exam, I'd be pretty worried, in large part because when you see the combination of hypoxemia and an elevated JVP, you know that the pretest probability of cardiogenic pulmonary edema is pretty high. And in a patient like this, when you go through your checklist of emergent causes of cardiogenic pulmonary edema, there's 3 major ones, one of which is in each category of the heart. So if you think of all the scary things you have to think about right away for new cardiogenic pulmonary edema, there's one endocardial cause, there's one myocardial cause, and there's one pericardial cause, the 3 layers of the heart. And the endocardial cause is any acute valvular issue. The myocardial cause is an acute MI, and the pericardial cause is an acute development of a pericardial effusion. And when you look at his history, you worry about all 3 of those possibilities. He's had cancer before. The most common cause of a diagnosable pericardial effusion is cancer. He's 87, so the probability of coronary disease with his hypertension is through the roof. And we know that he has a bioprosthetic mechanical valve that could easily fail. So when somebody like this has new decompensated heart failure, you really, really have to move very quickly. And the 2 things you can exclude with confidence, or some confidence based on any kind of imaging, chest X-ray, CT scan, point of care ultrasound, is a pericardial effusion, and which has been definitively excluded on the CT scan, and then an acute myocardial infarction. The question is, does he have a valvular disease process? And I think that question is very, very hard to answer definitively for one reason: he's tachycardic. And so your ability to appreciate a murmur related to his mitral valve is going to be very, very limited. And so you have to really not treat this patient just like your regular old patients with heart failure. and say, oh, you know what, they're acute decompensated heart failure. Let's just give them some diuretics and figure out what the cause is. This person needs an answer to their cause pretty quickly, in large part because of the possibility of an emergent cause, endocardial, myocardial, pericardial here under the valvular issue, but also because of the blood pressure. Hypertension in a patient with heart failure is a scary, scary scenario for diagnostic reasons and therapeutic reasons. The diagnostic reason is that it opens you up to the one major mimicker of heart failure, which is actually nephrogenic pulmonary edema, which is that the source of all the back pressure is kidney, heart. And that's a diagnostic consideration you should have in all hypertensive patients who have heart failure. And that consideration becomes more prominent, authentically should cross your mind, and then becomes more prominent when you hear the data that Prof. Rez will analyze. But from a management perspective, now you have to reduce the afterload in all patients with heart failure, and this person is definitely does not have a low afterload. That's even more important in a patient you're worried about has mitral valve disease. Picture this. You're a molecule of blood in the left ventricle. And if you have mitral valve disease, you now have two options about where to go instead of one. Ordinarily, you would just go up the aorta when the ventricle squeezes. But if the mitral valve is open instead of being closed, you now have the option of going up the mitral valve back into the atria, completely wasting your time and causing harm to the person's blood you're in. And so if you have a high blood pressure, you have much more resistance to go through the aorta. So you choose more often to go up the mitral valve. So this set of the combination of two things: one, the decent possibility of an emergent endocardial cause, plus hypertension is a very tricky setup. You have to treat this patient aggressively and seriously and not be fooled by the mere fact that he's on 2 liters of oxygen alone. One final point about the exam, which is the lung exam. We hear that the patient has decreased breath sounds at the right lung base. That could be many things. Before you know it turns out to be a pleural effusion, recognize the fact that mitral regurgitation can cause asymmetric pulmonary edema based on the pattern of regurgitation. So just because you have an asymmetric lung exam does not mean you don't have heart failure. So a lot of nuances here, but this patient is sicker than their vitals would have you suggest. All right, Prof. Rez, I'll pass the mic to you.
Absolutely brilliant, Robbie. Especially the point about the hypertension in the context of heart failure. Before I analyze this data, Gordon, do you mind filling? I think you were going a little bit fast, and it was hard for the scribe to keep up with you. Did you say was an echo done, or?
It was done, but I haven't talked about it quite yet.
Oh, you haven't talked about that. Perfect. And the INR was what?
The INR was 3.
INR was 3, and the PTT?
The PTT was 40.
40. Got it. Okay. This is really, really helpful. And right away, this case boils down to a lower extremity petechial rash, and by raise, it probably means it's palpable, plus hematuria with kidney injury and hypertension. So we see a lot of red blood cells in the urine of patients that come to the ED because they get a Foley catheter for one reason or another. But when you see hematuria in the context of someone with palpable petechia or palpable purpura, you see the difference between petechiae, purpura, and ecchymosis is just the size. They're all the same phenomenon. And the way you tell something is petechial, it means red blood cells have left the blood vessel. You can just take like a clear thing and push it on the patient's skin, and you'll see that there's no blanching because red blood cells have left the blood vessel. As these petechiae form together, they become purpura, and that's where the term palpable purpura comes to place. When you are able to close your eyes and feel the raised and the border of the petechial rash or the purpuric rash, you've diagnosed leukocytoclastic vasculitis, meaning when you biopsy that, it's almost 100% guaranteed you're going to have vasculitis. So now one red cell in the urine is one too many in the context of a petechial rash. And if we step back and just focus on the petechial rash, in reality, it can be related to platelet issues or clotting factors. But how many, I mean, his INR isn't too elevated. He's on a DOAC. A compression stroxin should not cause a petechial rash in him. Vasculopathy, not vasculitis, as we age, our vessels become more fragile and they're at risk of forming ecchymosis. That's why you see it in older people. They have, purpura and ecchymosis, but that's not this. This is in the dependent region of this patient's leg. So this is vasculitis until proven otherwise. And once you diagnose vasculitis in one area, the question is, where else can it be? And when we look at the urinalysis, the proteinuria is representing albumin. Albumin, high molecular weight, it shouldn't filter through the glomerulus. So something's causing that glomerulopathy, but I'm confident that it's not a glomerulopathy alone, but more specific, a glomerular nephritis, that you're losing albumin and you're losing red cells. You will study the sediment to look for dysmorphic reds and red blood cell casts, but quite frankly, it's very difficult to detect those, even for nephrologists. Then, interestingly, Robbie, the question becomes, in the lung, could there be vasculitis too? Are we being fooled by saying this is all H2O and it's not RBC? So I would be leaning towards edema because of what's happening with the heart being enlarged, but I don't want to exclude diffuse alveolar hemorrhage as I'm concerned for a vasculitis. And then when you went through your approach to the acute heart failure, myocardium, endocardium, pericardium, all of a sudden I wonder the coronary vessel, what's going on there? Could you have vasculitis of the coronary vessel causing acute coronary syndrome? I think when you're approaching this, you can approach it either from the petechial rash or from the GN. It's all the same. The question becomes, are you dealing with immune complex, ANCA, or anti-GBM? You'll send the ANCA serology, and ANCA is fair game, and it can manifest as such. You'll send the anti-GBM. And for the immune complex, it really comes down to either the complements are low, like endocarditis, like lupus, like other autoimmune processes like rheumatoid arthritis, or the complement is normal, like IgA vasculitis. I think in this case, we need a biopsy and we need it rather urgently. And I would actually probably advocate for 1 gram of methylprednisolone because I'm not getting a flavor of an infectious etiology. Everything is suggesting an autoimmune etiology. And this all of a sudden becomes an emergency with the GN that's happening in this patient. And his physical exam, he had ulnar deviation, he had PCP or PIP, MCP. That would be consistent with RA. And Robbie has this beautiful illness script on RA. And in men, especially if they have a smoking history, the serology tends to be very high, the rheumatoid factor and the CCP. And they tend to have extra-articular manifestations. And vasculitis is one of those. So Robbie, I just want to just pause for a second and dance. So I think from a management perspective, the question is this patient in a steroid deficient state of 1 gram of methylprednisolone? And we have to move quickly. We have to get the complements. We have to get the ANCA. We have to get the anti-GBM. And I would argue that we would RF, CCP, and going for a biopsy sooner than later so we can initiate, the immunosuppression that this patient needs.
Yeah, I completely agree with you. I think that the arthritis gives a lot of credence to a long-standing history of autoimmunity, and that certainly reinforces it. I think the question that people would be faced with in real life is when you have a vulnerability in your heart, namely you have a bioprosthetic, not mechanical valve. Do you worry enough about endocarditis to evaluate that definitively? So I think I think that's what people would be struggling with is if you take this valve and you make it not a foreign object and a normal native valve, I think you'd probably be moving much faster. But the measurable possibility that he has endocarditis of a bioprosthetic valve might give people pause to wait for an echo or wait to make sure that it's not hypocomplementemic or something like that. But the base rate of GN is autoimmune. That base rate is even reinforced when you see the arthritis. And then you have to take a little bit of a breath and say, he does have foreign material. What does that do?
I love that. That's a very good point.
All right, Gordon, tell us more.
Sure, thanks so much. So I can go into kind of like the additional lab work we got at this point. So he has a normal ESR and CRP. His rheumatoid factor was elevated to 46. He had a mildly positive CCP, and his vitamin C was mildly low. Things that were negative, negative ANCA, negative ANA, negative SCL70, rickettsial antibodies, negative cryo, normal TSH, and normal complement levels. We also got HIV, Hep B, and Hep C, which were all within normal limits. And then we got a urine protein creatinine ratio, which was 0.91. I think I'll stop there and then can share more.
Gordon, how many aliquots do you have until the answer is revealed?
I have one more slide and then the answer.
All right. Okay, so let's tackle this together, Robbie. I think the mildly low vitamin C is interesting. You know, vitamin C deficiency, scurvy, can lead to these perifollicular lesions that can mimic vasculitis, but usually it doesn't manifest as such. That being said, I would still give this patient vitamin C, and I would get a diet history to get a better sense of like what his intake has been. But the cases of vitamin C I have seen has been sort of a lot of just like small little lesions around the hair follicle. And patients do have pain because it does affect, you know, the bone marrow and the synthesis. In fact, they can present with anemia, those patients who have scurvy, but it would be, this is mildly low, it isn't undetectable. And there's too much else going on here with what's happening at the glomerulus. So I don't like scurvy as a possible answer here. The question becomes, what do we do with the elevated rheumatoid factor? Rheumatoid factor is like one of those non-specific antibodies, meaning it can be positive anytime the immune system is activated. So you can't get too excited about that rheumatoid factor being positive. Though, in someone with the physical exam findings of RA, you would shoot x-rays of the hand. And it, absent of what's happening right now, it would be a very good story for rheumatoid arthritis with the exam findings that Gordon presented. The CCP is more specific. That's just mildly elevated. Usually patients with RA, when they have extra-articular manifestations, those serologies are through the roof. I think the complements being normal, it lessens the likelihood of endocarditis. Usually that causes a hypocomplementemic immune complex mediated GN, but I don't know if it rules it out sufficiently. And Gordon, I'm sorry to ask you again, but did you get the echocardiogram or you haven't given that to us yet?
We did get it, but I just haven't talked about it yet.
Okay, got it. So
Sneaky, Gordon. He's sneaky. Watch out.
So I think that, you know, we'll see what the, of course, we're going to get an echo if there's like an obvious vegetation. Then the question might be interesting there, Robbie, because most of the time, I mean, we'll be running towards infectious endocarditis. You'd get 3 sets of blood cultures in this patient, but you just have to pause because patients with autoimmune diseases like lupus, like RA, they can be at risk of Lindman-Sachs endocarditis, meaning non-infectious endocarditis. And that one typically, I think the murmur might be more subtle, but it might, the lesion is more prone to embolize to places. So could endocarditis, non-infectious endocarditis, lead to a particular rash, lead to a GN? The answer is absolutely it can. So we'll see what the echo shows, but even if the echo shows the vegetation, I wouldn't run. I mean, I would prioritize infective endocarditis, but in the back of my mind, I'd be open to an autoimmune mediated non-infective vegetation as well, and specifically in this patient. The proteinuria just confirms our hypothesis that we're dealing with a nephritic syndrome, hypertension, lower extremity edema, proteinuria, hematuria. You have it, it's all there. But something's going on at the level of the heart, and I think Robbie picked up on that quite well. So we'll see what the echo shows. But Robbie, anything else to add for this aliquot of information?
Poetry, my friend. I completely agree with everything you said. There's it's a desert now. There's nothing left to say. All right, Gordon, right to you, my friend.
Sure. So the next aliquot will reveal a diagnosis, but at this point, the micro lab called us, and he has blood cultures, 4 to 4 blood cultures going, GPCs in chains and clusters. So I guess just before I reveal like the diagnosis, I was wondering what workup you would want at this point, or any additional, imaging or lab tests at that point.
Very, very humbling, honestly. I think even though we were thinking about endocarditis, I think that it just goes to show you how you just have to be very, very careful when a patient has any metal or anything. I keep saying metal. Prof. Rez texted me. He's like, man, you said it's a metal bioprosthetic valve. What does that mean? Yeah, I think it's just humbling. Gordon, I'll tell you why I'm asking this question. Well, one, I should just ask you, I'm really curious. What prompted you all to order the blood cultures? Because I think Prof. Rez humbled me with a very similar case, and I'd love to learn from you. Because if you hadn't ordered it, nobody's making this diagnosis. So I'm curious what your insight was to even do so.
Yeah, I give a lot of credit to this to Mark, but this was like a case that really, stumped us, and we were thinking like a broad differential, and he just kind of had like a very nice schema for both petechiae and endocarditis, which we thought would be, pretty low on our differential, but just I guess with how broad we were being in our initial workup, we thought at least one set of blood cultures would be helpful.
Very smart. Yeah, I'm really grateful to you, Gordon, for sharing this lesson with everybody here. And quite honestly, I owe Prof. Rez a big debt of gratitude for like really wiring this very hard in me, because he presented a case on RLR CP solvers. And I will plug that again 2 days in a row. You guys, if you're not subscribed to all our CP solvers, I promise you're missing out a lot. And if you're an IMG, you get a 50% discount. So really, really check it out. And Prof. Rez completely bamboozled me a month ago. I think he's nodding his head now, remembering. And I completely missed it. And we reflected on this exact same question. And I spent so much time thinking about it. And now I've modified my illness script for endovascular infection to be less leaning on signs of inflammation. I think in med school, I learned that endocarditis means crazy white count, crazy fever, to much more actually lean towards the vulnerability. Most people with endocarditis have a vulnerability. And if there's a vulnerability, you got to think about that. And the vulnerability is anything vascular, be it there's injection into vessels or material in vessels or previously damaged vessels or atherosclerotic vessels, any endovascular problem. And so now when you're like, there's something wrong with the endovascular system here, the patient has heart failure and they have an endovascular risk factor, think about it. But I think as we try to figure out what the issue is, we need to try to predict what the microbiology is. And so when we're talking about GBCs, we're talking about gram-positive cocci, and you have 4 possibilities as to what they are. If they are in clusters, it's likely to be staph. And the question is it Staph aureus or coagulase negative staph? If they are in chains, it's more likely to be Enterococcus or Streptococcus. Now, all that doesn't matter in the moment because you're going to know what these are. But this is a very intriguing report. This is a very intriguing report, Gordon, because you're saying that what the microecology with is they are both in clusters, evoking the idea of staph, coag positive or coag negative, Staph aureus or coag negative staph, and that they also appear to have some chain form to them, suggesting strep or enterococcus, which is a dilemma that I've never been in. I think the most morbid hypothesis would to wonder, does this person have polymicrobial bacteremia, has many different bacteria? But I think this person now has endocarditis until proven otherwise. And the good news is that you'd probably start with vancomycin immediately and then tailor your antibiotics based on what actually grows out. And then pursue the beloved echocardiography to help you visualize the second aspect of the diagnosis of endocarditis, which is that you see something in the heart. And hopefully you'll be able to do that with a TTE, but you may need more invasive imaging to do so. Prof. Rez, I know you're on the move. Anything else you want to add or reflect?
Yes, I do. Thank you for giving me the space. Gordon, was there a murmur?
Yeah, I can, on the floor, when we reassessed him, we could definitely appreciate a murmur. It was really hard to hear in the ED, but definitely could appreciate on the floor where it was a little quieter.
Yeah, no, that's totally fair. Yeah, that very humbling case. But yeah, I think Robbie, you hit the nail on the head with the bioprosthetic valve. And it just shows you, like, elderly patients may not mount that fever, that high white count. Even younger patients may not mount it. But I think at the end of the day, if you approach this from just the cardiomegaly and the low EF, it would be on your differential diagnosis, trying to localize endocardium, myocardium, or pericardium. Thank you so much, Gordon. Really appreciate you, man.
Prof. Rez, where are you going?
I am going to the orchestra, my friend. But I better run.
Have a good time, okay? Yeah, Gordon, what you got next?
Sure. So his blood cultures ultimately speciated strep mutans, which were susceptible to ceftriaxone. It's presumed to be from an oral source. He had a very poor dentition, which I didn't mention up front. And then I mentioned he did have the murmur when we reassessed him on the floor. He had a TTE done, which showed severe MR and moderate TR. His prior TTE to that was from like 2 years ago and just had mild MR and TR. We ultimately got a TEE, which did confirm vegetations and confirm the worsening valvulopathy. And he had an outpatient dermatology punch biopsy prior to his arrival that confirmed leukocytoclastic vasculitis. And ultimately, ID was consulted for endocarditis, and he was started on 6 weeks of IV ceftriaxone with outpatient ID follow-up.
Absolutely amazing case. There's so much to reflect on and think here. And I think, Gordon, you presented it so well and so efficiently that we have about 5 minutes to spare before teaching points and whatnot. And I'd love to take advantage of that and actually just have folks go out into breakout rooms if you have that availability to just like reflect on this case, share what you learned, and then we'll come back and hear your reflection, Gordon. So yeah, let's just take a few minutes in the breakout rooms to get to know each other and to reflect on what is a mind-blowing case. If you aren't unable to join, don't worry about it. Just hang tight for a few minutes and we'll all come back here, okay? All right, I hope you guys had fun, reflected, and hopefully more clarification than confusion, though sometimes more and more questions come out in these very, very complex cases. Gordon, I'm curious, what was it like for you to take care of this patient? Walk us through what your journey was and what your reflection is.
Yeah, I think I just have to say this was like probably the nicest patient I've ever taken care of. So it's like always like fun, just like, taking a history from him was always like, a very enjoyable experience. And I really I feel like stretched kind of like the limits of my knowledge as an intern of, just having like a very broad differential for rash and for petechiae. I think like what you said with him kind of being more vulnerable, kind of like tipped us into the cardiac bucket. Like he had this mitral valve repair. He also had this edema that we didn't really have like a great explanation for. Like he wasn't having typical CHF type symptoms. And then I think the fall and like the chest trauma, like like the mild like hemothorax, was something that was like kind of like almost like a red herring and like something that we had to kind of separate from our other issues. So I think, the takeaway for me was to kind of like constantly like reframe my differential based on the information that was coming back because we ordered such a wide array of lab testing, and then also to continue to refine my assessment based on the exam. And then once I heard the murmur, the TTE was more urgent at that point.
Yeah.
I think that there's so much wisdom in there, and I appreciate you sharing all of it, and more importantly, sharing that not just with yourself and with your team, but with so many more people. Really, really appreciate it. And I think it's a very humbling lesson in the ever-ending dance between the heart and the kidney. And there's, we talk stereotypically about the battle between cardiologists and nephrologists and how they always argue with each other, but it's true because their organs talk to each other a lot. And this is probably the most esoteric way they talk to each other, where a heart infection causes a autoimmune condition in the kidney. Very intriguing, but very important to diagnose and not get distracted by. Because you're probably going to worry about the heart first, get distracted by the kidney, but then have to go back to the heart. And I think that's a complicated journey to have to make. Before we hear from Ambish, I'd love to get your reflections. Mark, what was it like to take care of this patient and to work with Gordon on getting a diagnosis and treatment?
Yeah, I just want to say thank you for Gordon for, presenting this case. Gordon is such a star, and he's ready to be a senior resident such early, early on an intern year. I'm sorry if I'm a little, probably sound a little delirious. I'm on nights right now, so a little tired. But Robbie, going back to your question too, I think there's one additional thing that also like made me, consider ordering blood cultures in the ED. One, definitely the vulnerability with the mitral valve repair and then the new heart failure symptoms. And then two, kind of like, as Prof. Rez kind of laid out this like beautiful differential for petechiae, I think of like hemostasis issues, thinking of blood vessel issues. We kind of ruled out like hemostasis issues. The patient's INR was 3 on a DOAC, but petechiae are just not common manifestations of bleeding from a DOAC. And then kind of moving to blood vessel issues. And when we touched on vasculitis, like usually, at least in my experience, patients with small vessel vasculitis, ANCA, these other causes of vasculitis, usually these patients are very systemically unwell and very systemically inflamed. And this patient with like normal inflammatory markers and not really having many inflammatory symptoms at home really kind of pointed me away towards that. And with the vulnerability and there's absence of like really prominent like inflammatory signs at home, maybe really just at least get those blood cultures in the emergency room and get the echocardiogram and kind of see what comes back. So yeah, this case was a lot of fun. And just to think that endocarditis can really just present as a bilateral petechial rash without a fever is really cool.
True that. That's a great sentence to end the complexity of medicine. Gordon, thank you so much for preparing this case and coming here. It's virtually impossible to do so as an intern, and we really hope that this is just the beginning of your cases here, and we see you more often in VMRs. Are a real treat. I'll pass the mic to you, Ambish, to take us home.
Thank you, guys. That was a very interesting case and a lot of learning going on. Before I get started, I just want to give a shout out to everybody in the chat. I feel like I'm not just learning from the people who are performing the dance, but also the people who are typing everything in the chat. So I'll just get started with a quick summary. Today we had an 87-year-old male with a history of atrial fibrillation who was on anticoagulation. He was hypertensive and has a history of a remote melanoma, who presented in the ED with a 1-week history of bilateral lower extremity rash, which was associated with edema. That was followed by the discontinuation of the compression stockings. The rash was progressing in the setting of a recent fall with chest trauma. The clinical findings were significant for hypertension with signs of volume overload, decreased breath sounds on the physical exam. There was pitting edema and petechiae. And then the lab investigations reveal lymphopenia with neutrophilia and monocytosis. The urine analysis was suggestive of renal involvement, but so there was involvement of 3 main systems: the heart, the kidneys, and the skin. Right. And in the chat, I was seeing a lot of you, especially Andrew, was anchoring on to the possibility of an endocarditis. And reflecting at the case now, I see that there were a lot of risk factors present, right, which could have been overlooked when you're looking at the broader picture. But when you bring it all together, now it all makes sense. So as per the teaching points, I'll just try and keep it brief. So when you take a rash into account, the first few things to look for are the width, the depth, the involvement of the rash, and the involvement of the different areas, as Rabih highlighted. And then So basically, you want to see the quality of the rash. You want to see whether it's erythematous, because that would lead to a completely different differential compared to a confluent rash, which would then be a different ball game. And then Reza mentioned that half of the population has venous stasis by age 50. So that's an important consideration. Our patient was 87-year-old, so chronic venous insufficiency is a common thing to keep in mind. And then something Andrew mentioned in the chat, which I put on the whiteboard. I often do that. Something interesting that is in the chat, I often put that on the whiteboard. So purpura is the most common dermatological finding in endocarditis, not the oscillars and the Janeway lesions. And then Rabih highlighted the fact that if the rash, Rabih and Reza were talking about how everything is interlinked, and if you go into the depths of the HPI and everything, you can see a trend, and it can help you understand, is this rash a causal rash or a contributory rash? And so the sequence of events can give you a lot of information. So being vigilant and taking a good history is also very important. Then in setting of a new cardiogenic pulmonary edema, there's three things to keep in mind. It could be endocardial in origin, which could be due to an acute valvular lesion. It could be myocardial due to an acute MI, or a pericardial effusion, let's say due to a malignancy. Something that really struck me was Rabih mentioned that hypertension in heart failure patients is very scary. And so you have to be very, on top of everything in terms of treating the patient, managing and trying to diagnose at the same time, because hypertension in a heart failure patient can have a poor prognosis. Then another thing that was important and worth highlighting is the asymmetry of the lung exam, and it should not make you rule out heart failure. And then something else in terms of management, we're trying to diagnose the case, but at the same time, it's very important once we've identified that there's some inflammatory process going on. We were thinking along the lines of a vasculitis. It's very important to suppress the inflammatory process. So in that setting, it's important to use methylpred, and then an urgent biopsy would be needed. Sending serologies is important. And then something Prof. Rez mentioned, which I really liked, was that men who are smokers, these small associations can, help you a lot when trying to diagnose in an emergency. Men who are smokers, they tend to have high serology, high rheumatoid factors, and we did see that in this patient, as well as extra-articular manifestations. Finally, something very basic when it comes to hypertension accompanied with lower extremity edema and proteinuria, you want to think of nephritic syndrome. And then again, something very basic, it's good to revise these things, come back to these. If you're looking at gram-positive cocci, you want to see whether they're existing in clusters versus chains. So when clusters, you're thinking of staphylococci, and when you're thinking of chains, you're thinking of enterococci or streptococci. And then finally, when I look back at this case, there were a lot of red flags that were pointing towards endocarditis, the new murmur that was appreciated, sometimes poor dentition, and these patients can have a dental procedure that could lead to vegetation, and then the artificial valve. So that is it for the teaching points. Thank you all.
Ambish, Kiara has her mind blown, 3 fire emojis and 3 clap emojis for you. I think that summarizes it very, very well. That was outstanding. Really complicated case, so well summarized. Thank you for that. And thank you for adding in all the wisdom in the chat too. I think that's a nice twist. It certainly amplifies all the learning out there. All right, y'all have a wonderful day, and we'll hope to see you at the next VMR. Bye.